G'day. Welcome back to the Sports Medicine Project. Now, I apologise for my voice. It sounds a bit hoarse, a bit croaky, but for bloody good reason. We've just been at the Newcastle Knights home final and they won 30-28, absolute nail biter, extra time, lots of screaming. Voice isn't doing too good, but that's okay because we are here for part one with Professor David Hunter. Now, the topic that we see probably the most about online, I think, in the research world is knee osteoarthritis. One of the statistics that Professor David quotes in this podcast is around I'm pretty certain it's around the disability in the community population. When we talk about OA, it's knee osteoarthritis. So it's one of the most common, and things that we see on social media and research that comes out, people are certainly talking about what we can do and how we can help people with knee OA. So we talk about osteoarthritis generally and on a systemic level and a more general level, and then we talk about knee specific OA as well. Now, to give David a bit of an introduction, he's a rheumatologist and a clinician and a researcher, which is, having those three together is awesome. So he sees patients, he's doing research, he's doing it all. His primary research focus is clinical and translational research in osteoarthritis, and that's down at the University of Sydney. Now, he's ranked as the leading expert in the world on osteoarthritis on expertscape.com, and he's the section editor for Up to Date Osteoarthritis and the editor-in-chief for Osteoarthritis and Cartilage, which is an awesome journal. You guys need to go check it out. And if you're looking to find him on Instagram, just type in his name. He's got an awesome podcast and creates lots of good evidence-based content and has the ability to be able to translate it so well. He's got over 600 publications in peer-reviewed journals. Now, I'm certainly not going to lie, I haven't read all 600, but I'm going to tell you guys about two that I really enjoyed reading. So he's got one titled Acupuncture and Knee Osteoarthritis, Does It Matter, or Does Dose Matter? And cost effectiveness of diet and exercise for overweight and obese patients with knee osteoarthritis. So if you have a listen, go and check those two out. Those were my two favorite. So as well as all this, he's also the co-director of Sydney Musculoskeletal Health and leads the osteoarthritis team at the Coling Institute. And basically they are dedicated to improving the understanding of osteoarthritis and the quality of life for those who suffer. So great podcast. Part one was awesome. We spoke for about an hour and 5 minutes. So we're going to have part one, part two next week, of course. Now, a couple of things we spoke about. The questions probably come across quite simple, but I think that there is so much out there. It's great to have a really nice, succinct answer to those simple questions. So the first one, of course, asking him if he can just explain OA and how he explains it to patients, but also clinicians, talk about the pharmacological treatments and what he's seen to be effective both clinically and in the research. Is osteoarthritis a true wear and tear condition? Is there an orthopedic cost to activity? I really like that one. And we talk about the study in marathon runners versus recreational runners versus sub-elite, where it's the inverted U. So if you do lots of activity, we know this is the second biggest risk factor. It's joint trauma for knee osteoarthritis. So if you do lots of activity, there is the argument that there is probably a ceiling for how much you can do before your risk does start to increase. How does weight influence pain and prognosis in OA? What do we think is the driver of pain in someone with OA? That was awesome. Talk about the systemic drivers. That was really cool. And why joint replacements are so successful if we're not sure what the driver is. So if we're talking about these multifaceted nature of pain and these other psychosocial influences, how do we see that, or why do you think that the joint replacements are so successful if that's purely on the mechanical level? But of course you can't do surgery without having those psychosocial things attached. But it was good. And of course, exercise therapy. We talked a little bit about the study recently with saline injections versus the osteoarthritis strengthening program. It's funny, the thing that I took away from that, and I've heard this multiple times, when we talk about saline itself as a placebo injection, I'm thinking this in other research in the podiatry world, like footwear as a control shoe or this orthoses and things like that, it's very hard to have a really neutral standard placebo because, whenever we give something, there are things attached to that. But also on a local tissue-based level, injecting someone with saline, the pH can change within the knee, and also injecting fluid in there. He puts up an awesome statistic, but I can't remember what it is, how for every percentage change in knee volume, that can help with something. I'm going to have to re-listen to it now, but it was great. Lots of little clinical pearls like that, so I know you guys are going to like it. So enjoy this episode with David Hunter for part 1. And if you are interested, our Patreon link is down the bottom, helps keep the lights on. It is basically just Kelly and I discussing case studies and research and doing some little online videos and some orthotic scripts and exercise prescription for runners or an Achilles or a knee or a hip stress reaction and things like that. So it's slowly growing, which is awesome. People are obviously finding it pretty engaging, and we're going to start to put a little bit more time into that because it's fun to be able to talk into that much depth about specific cases, and you can, explain more of the nuances, which is always difficult when you've only got a shorter period of time. So enjoy this episode, guys, and go the Knights. Welcome back, sports medicine fans, to another episode of the Sports Medicine Project. Now, of course, every single time I say this, I'm very excited. We have Professor David Hunter on today's episode. Now, thankfully, he's a little bit closer. Our last guest was all the way over in Chicago. Now, he's down in Sydney. Is that right?
That's it. Exactly right.
Beautiful, mate. Thank you so much for coming on.
My pleasure. It's great to be here.
Now, you've got a very extensive bio, and I've shortened it a little bit, but we're going to ask you kind of what keeps you busy and how you got there. But you're a rheumatologist, clinician, researcher, which is awesome that you do all three. It's great to have clinicians and researchers on. And your primary focus is clinical and translational research in osteoarthritis. And you're currently the co-director of Sydney Musculoskeletal Health and lead the osteoarthritis team at the Coling Institute, which is pretty awesome. It's a lot.
Yeah, no, it keeps me out of trouble. That's for sure. Not as much time for play as I would like.
Now, there's a few things that you obviously do during the week, but what does an average week look like for you between everything to do with kind of being a clinician and a researcher, and how did your career progress to where you are now?
Yeah, so I'll touch upon the average week first, and then hopefully get in a little bit to how I got to where I am at the moment. But the average week is, a huge variety, and that's the beauty of the job that I do, is that, I probably spend about a day a week seeing patients, and most of those are in a multidisciplinary osteoarthritis program. So I get to see patients alongside physios, podiatrists, orthotists, dietitians, psychologists. So that's a wonderful opportunity for me to interface with patients. But again, that's just a day a week. And the remainder of the time is more of an academic role. And that academic role involves both teaching, and most of that teaching these days is both for PhD students and postdocs. And at any one time, I'll usually have 6 PhD students that I'm supervising. And obviously my own research. And I have a team of about 30 people that I have the privilege to lead. And we're working on a variety of things in osteoarthritis, including epidemiologic research, looking at reasons why people develop disease, risk factors for disease, looking at some biomarkers. We have a particular interest in developing imaging measures for disease-modifying trials. We do a lot of clinical trials, and those clinical trials would extend all the way from diet, exercise, bracing, supplements, through to, again, pharmacologic interventions with a particular focus, again, on disease-modifying therapies. And then we do quite a bit of health services research. So that's looking at the care that people receive, what they should receive, and ways we can do things better, basically. So that's, I guess, my average day. My average week is probably about 60 hours of work, not enough play, as I mentioned before. But when I'm not at work, I enjoy kayaking, mountain biking, swimming, and spending time with the family. And how I got to be where I am now, it's sort of, I don't know whether you want the short version or the long convoluted version.
No, the long version is always interesting.
So I was lucky enough to grow up in a dairy farm on the south coast of New South Wales, a little place called Jamberoo. And, my family has a long history of osteoarthritis. And in particular, I guess the first person that I kind of knew that had osteoarthritis was my grandmother. And she'd had it for a few years and I didn't think too much about it. But I guess when I was a junior resident, so junior doctor, I was overseas at the time. And she was incredibly close to me, and we grew up spending a lot of time on the farm playing weird card games. And she was someone who had, a great reverence, a great respect for community, but also a great disrespect for authority figures that don't really contribute much. And so she was someone who was incredibly close to me. And so I received a call when I was overseas at the age of I guess I was probably about 24, 25. And my mom had said she'd had a joint replacement. And about a week after the operation, I didn't even know that this was happening. About a week after the operation, unfortunately, she passed away due to complications from that surgery. And this was done by all means by a low-volume surgeon at a low-volume hospital for a procedure that she really hadn't been offered anything else other than the joint replacement. And so, I guess on the back of that, and probably subconsciously as a consequence of that, I guess I've set my professional life's mission about trying to pursue better therapeutic paths for people who have osteoarthritis, so that it's not just about high intervention and high cost and potentially high risk procedures, and hopefully provide alternatives for patients that give them alternatives to care, routes of healthcare access, and hopefully don't follow a similar path to my grandmother. So yeah, anyway, that was probably subconscious back then, but it probably became more at the forefront of my mind as I matured in my career. And originally I wanted to be a sports doctor, but at the point in my career where I wanted to do that, it wasn't really recognized as a specialist pathway. And I know they're still struggling in some ways in that regard. And a couple of the mentors that I had along my career path were Olympic team doctors and rheumatologists, and they sort of took me under their wing and helped shepherd me along that pathway, and obviously began focusing on a disease that most rheumatologists don't tend to focus on too much because they probably don't feel there's a lot they can do for it. But it sort of shepherded me in the direction of research so that we can actually develop new therapies and hopefully change that mindset for most clinicians who are out there.
Wow, that's really interesting. I am interested, what's your preferred side of your career, the clinical side or the research side?
That's a good question. I love both. Yeah, I know I'm dodging your question, but honestly, if I just had to singularly focus on one, I think I would get distracted. And I don't think I would serve either one particularly well. But, the beauty of being both is that way, at least in a clinical context, I get to deploy new innovations to my patients and hopefully cutting edge therapies that many clinicians probably don't otherwise think about. And then at least from a research perspective, get to apply those interactions that I have with people with osteoarthritis to the questions that I'm posing in my research. And, I think oftentimes researchers tend to go off and really abstract tangential paths that potentially are not as well informed by clinical care as they could be.
Do you think overall, like as a collective, the research is moving in a positive direction? Like we're getting closer to being able to solve the big questions and the big problems that clinicians generally face each week?
Oh, undoubtedly. And I think research is becoming much more focused on translation. And at least in the osteoarthritis context, at least for me, the two big holy grails that I think will be tackled during my career will be preventing disease and also developing treatments that can modify the course of the disease. So not just, not just tackle symptoms, but actually tackle the disease itself. And so I think both of those will be solved during my career.
Yeah, and it certainly moved. I mean, we see as clinicians and even the research as well, and what we read, it seems to be more moving towards what preventative stuff we can do, if we can do anything, and that's always the big question, rather than curative, once you've got the disease, then what we can do.
Oh, undoubtedly. And I think there's a lot that clinicians can do about prevention, and at least the interventions that we're testing around prevention are readily available and accessible. So we've just been funded by the National Institute of Health in the US to do a prevention trial targeting women over 50 who are carrying excess weight and getting them to lose weight, and see if we can prevent the disease, the most common risk factor, and its impact it has on disease. So that's a trial we're about to start. But that diet and exercise intervention that we're going to deploy is readily available already. We just don't have the trial evidence. We've got observational evidence to support that it works. We don't have currently the randomized controlled trial evidence to suggest that it works. So that's something we're pursuing over the next 5 to 6 years, and hopefully will lead to a mind shift in the community about ways we can approach this disease. And obviously the second biggest risk factor for disease is joint injury. And we know we can prevent most of those from happening. But again, not much necessarily happens around neuromuscular training and prevention of joint injuries. And that should change.
Yeah.
How much do you feel we can prevent osteoarthritis when we're also battling against the non-modifiable risk factors like genetics?
And I'll just add to that, is this specifically to the knee or generally overall?
So yeah, I mean, it's a great question. So I'll tackle the second question first. So at least from the viewpoint of when we talk about the morbidity associated with osteoarthritis, about 85% of community burden relates to knee osteoarthritis. And it's not to diminish the impact that hip and hand osteoarthritis has on people that are affected by it, but it's a smaller impact on the community as a whole. The risk factors for disease in hip, hand, and knee differ. And so what I was talking about there was really related to knee osteoarthritis. And we know for hand and hip osteoarthritis that genes and familial risk play a much more important role, and particularly for hip, the role of shape and potentially adolescent activities play an incredibly important role in predisposing to disease in the hip. For knee osteoarthritis, the two biggest risk factors are obesity and overweight and joint injury, and they account for about 75% of what we call the population attributable risk. So the reason why a person develops disease. And it's not to say that genes and family history and occupation and those sorts of things don't play a role, but they're much lesser role than they do play for other joints. And so, at least for us, when we're thinking about, the biggest impactful joints and the modifiable risk factors, both of those risk factors are eminently modifiable, and we don't do too much, if anything, about them. Now, I apologize. Did I tackle both questions, or I forgot one?
Yeah, no, you did. You did.
Okay. Yeah.
Yeah, you've touched on it a couple of times, and it's a question. I was only first made aware of it actually by you, and I know you were speaking with a physio about, some research that was looking at kind of osteoarthritis as a disease, it sounds like a bit of a buzzword, but like low-grade inflammation. And I certainly know it's not that simple, but how weight and those things can influence the progression of the disease and the symptoms. Can you kind of speak much to like how weight and I know BMI is not great either, but how weight can influence the prognosis and people with OA?
Yeah, for sure. And, it's a really important point. And historically, osteoarthritis used to get labels like osteoarthrosis, and it used to be contrasted with other inflammatory types of arthritis and thought of as a non-inflammatory disease. But, the itis in osteoarthritis refers to inflammation. It's a term that, is an apt descriptor. Pretty much everybody who has osteoarthritis has inflammation somewhere within their joint. And, if we do MRIs on everybody that has osteoarthritis, and I'm not advocating that we do that because that leads to a lot of unnecessary care, we see synovitis pretty much universally in everybody. So it's part and parcel of the disease. And, at least in terms of what causes that inflammation, it's likely a byproduct of a few different things. And so if we look at the mechanical changes, the aberration that occurs in the context of osteoarthritis, we know that joints undergo damage. Some of the cartilage and meniscal debris that occurs in the context of osteoarthritis gets taken up by the lining of the joint, the synovium, and that creates an inflammation. So in contrast to rheumatoid arthritis and other types of autoimmune disease like that, the synovitis in osteoarthritis is likely a consequence of the mechanical aberration. But in addition, it's perpetuated by excess weight. And so we know that about 90% of our patients that have osteoarthritis are carrying excess weight. The average body mass index in most of our cohorts is about 31, 32, which puts them not just in the overweight category, but in the obesity category. And that plays an incredibly important role in predisposing to disease, facilitating progression, and we'll probably get into that in a second. And why does that happen? Well, it happens for a couple of different reasons. So one reason is just through pure mechanical loading. So for every additional kilogram that a person carries, there's 4 kilograms of excess load goes across their knee during any weight-bearing activity. So, every kilo that they take off makes a big roll to excess load. But the other aspect to this is that carrying excess adipose tissue or fat creates circulating inflammatory molecules or cytokines, which perpetuate the inflammation that goes on locally in the joint and facilitate the damage that's occurring locally within the joint. So it plays both a mechanical loading role and a circulating systemic inflammatory role. And so that's why weight plays such an incredibly important role and has a really important role both in, as I said, developing disease, but also facilitating its progression.
Yeah. If you were to divide it between, say, mechanical and that systemic inflammation or the cytokines going around the system, losing weight would obviously address both of those things. I guess you can never do one without the other. Is it possible to work out, or do we need to understand which is more contributing to the discomfort that people get?
Yeah, it's a good question in terms of why do they get pain related to obesity? It's a combination of both. I mean, if you eliminate load through, like a zero gravity treadmill or getting a person to wear a brace that realigns the joint that takes the load off that compartment, they'll still have symptoms, and it won't necessarily ameliorate all of the symptoms that they have related to that activity. So, by just targeting one, I don't think you address the underlying problem as well as you could by targeting both. And we know from weight loss studies that we see improvements in loading of the joint, but we also see improvements in those cytokines that I was mentioning before. And so, to me, the rational approach to this is not just taking the load off the joint through, realignment surgery or joint replacement surgery or wearing a brace or something like that. It's really to try to address the systemic risk factor here, which is the excess body weight.
Yeah. And that seems to be, we've got so many studies now, looking at just resistance training and exercise is great for, knee osteoarthritis, for conditions all over the body, symptoms of depression. It seems to be the hardest thing is having people stay engaged and be consistent. Do you find that as well when it comes to this kind of scenario? It's just how do you get someone to stay and engage? We know it seems to work, but people just can't do it for that long and very long.
Yeah, I mean, behavioral change in all of these aspects is an incredibly difficult mountain to climb. And, I think that's, again, one of the aspects of care that, I'm privileged to work alongside people like you guys that are really great at behavioral change. And so, if we want someone to lose weight, it's all well and good for me to sit there and tell them to lose weight. But if I don't give them the tools to do so, or if I don't give them the tools to apply exercise and monitor their technique and stay adherent to that, and or to improve their mood long term, it's never going to happen. So we pay great attention to that in our clinical practice. And again, I'm spoilt by the fact that I get to work alongside allied health people who target those particular aspects of care, whether that be mood, strength-based or physical activity type prescriptions, as well as diet. Because again, if you don't give people the tools, if you don't follow them long term, they won't stick to it. And we know the biggest challenge here is that of adherence. And we've got great data now suggesting that we can get people to lose weight, to exercise for sort of 18 months, 2 years. But then when we let them go and we get them to do their own thing, and we're not necessarily following them up anymore, their adherence to that long term is problematic, and they tend to get the symptoms back.
Yeah, which then just calls for more research into the whole understanding of weight loss and consistency and things like that.
Yeah. I mean, there's undoubtedly need for us to go more into this, but I guess also to look at the societal reasons why people can't keep the weight off. So, if we're good at, I guess, getting people to get the weight off, but in an ideal world, that they A, wouldn't gain the weight in the first instance, and B, there wouldn't be the societal risk factors as to why they continue to gain weight. So, if we're starting to look at things like the built environment. So what's the activity around a person's house, their workplace that facilitates and promotes physical activity? Are there, obesogenic environments that are stimulating them to go out and make unhealthy food choices? Oftentimes it's a lot easier and cheaper to buy unhealthy food than it is to actually make healthy food choices. So we're starting to look into some of those reasons as well, because it's not, I don't think the solution long-term here is going to be the individual dietary and physical activity prescription. We actually have to change societal impacts here, because, 2/3 of Australians are overweight or obese.
Yeah.
We always look at America and say, that's a terrible country as far as body mass index is concerned, but Australia's really no better.
Yeah.
So unless we have some brave public policy decisions here around promoting activity, promoting healthy food choices, banning junk food advertising, and those sorts of things, this isn't going to change.
Yeah. Can you explain what osteoarthritis is and how you explain it to your patients?
Sure. So it's a disease of the whole joint that manifests as pain and limited function. And what I try to do is keep it quite simple and then move on and talk about what they can do about it. And so, historically, again, a lot of the conversation used to be around this being about cartilage. And it's not just about cartilage. And the reason I say that is because cartilage doesn't contain pain nerve fibers. And it's not the reason why a person presents to you complaining of pain. So that's why I say it's a disease of the whole joint, the whole synovial joint, that manifests as pain and limited function. And then go on and talk about some of the modifiable risk factors that they can fix in an effort to try to improve their pain and function and help their long-term prognosis. Because again, the long-term prognosis for most people here is favorable if they're able to stick to, that simple mantra of get strong, stay active, and maintain a healthy body weight.
Yeah. I feel like something that I often run into a little bit of a brick wall with when treating patients is a lot of patients know that, they think that they know that eventually they're going to need a knee replacement. So they're like hedging all their bets that that's going to be successful at some point in the future. And therefore they think that until the knee joint itself changes, their symptoms and their function isn't going to necessarily change. How do you approach that, and what's the conversation that you're having with patients around, other things that might be influencing their pain and their ability to function?
Yeah, well, I guess I try to be as positive as I can, because I think that in the first instance, it's probably a bit of a misconception. So if you look at the natural history of osteoarthritis, the natural history for most people, about 10% of them during their life course will require a joint replacement. So it's by all means, it's the minority. The vast majority of people never need a joint replacement. So I think it's important to say that to people, is that most people, the prognosis is good. They generally do very well. If anything, as far as the trajectory of symptoms are concerned, it's pretty flat. And most people don't experience the deterioration that I guess the community perception might suggest. So I think just try to be positive, try to suggest to them that if they're able to stick to those simple messages I was giving a moment ago, their prognosis is actually generally very favorable, and they're unlikely to experience the deterioration that many people are concerned about that requires surgery, and that, they'll end up in a wheelchair and unable to mobilize, which I think oftentimes is people's concern when they first present. So just be positive about the prognosis. Say, generally for most people, surgery is not part of what they should be able to expect, and try to put to bed some of the, I guess, community perceptions that may have stemmed from inappropriate language that comes from health professionals, including us. So, the use of terms like degenerative, bone on bone, wear and tear, oftentimes lead patients to believe that there is a mechanical aberration that can only be fixed by a surgical intervention. And we know that that's not true. We know that there's lots of other therapies that will help a person with osteoarthritis to improve their pain and function long term. And it's not just about surgery. And for most people, they never need surgery. So again, try to be positive, try to, as part of that conversation, reinforce to them the importance of sticking to treatments that we know will help them favorably long term. And I guess the other aspect to this too that I think is important to reinforce is, and I apologize if you're going to get into this, is that this is a systemic disease. For the vast majority of people, they will have 3 to 4 joints that are affected, and usually on average 2 to 3 lower limb joints. So that even if they think that they're going to fix the problem by replacing a knee, they know that they're likely to have at least another knee and or a hip that's affected. Now, you'd like to think that they come along to you and they say, well, as soon as I get my knee fixed, I'll be able to walk and I'll be able to lose weight as a consequence of the fact that I don't have so much pain anymore. But the reality is, despite that, most people's physical activity does not change, their diet change, their body weight doesn't change. So the risk factors for those other joints remain the same unless you do something to address them.
Yeah, that's a really good point.
Is the prognosis quite good overall that people do generally get a complete resolution of pain? And is there a time frame for that, like 5 years or 10 years, or do we have any research on that currently?
So again, at least in observational studies, if you do nothing, the trajectory for most people's symptoms over a 5 to 10 year period is very flat.
Yeah.
There's probably about 10% of people, and these are probably the people who are going off to have their joints replaced, where the trajectory is one of worsening. We know that in clinical trials and again, observational cohorts of intervention type programs like our osteoarthritis chronic care program, that the overarching trajectory is one of improvement, and that can be maintained usually over an 18-month, 2-year period. And that's as long as we generally follow people in those intervention programs. And so again, it's flat if you do nothing. It's one of general improvement if you do something about it. And the very small minority of people will get worse. And oftentimes, you can predict who those people are going to be based upon adverse risk factors, whether that be, the body mass index, the alignment, mood, and or other things that might predict those.
Yeah. Do you currently think at this stage, thinking it's a joint and certainly mechanical load goes through the joint and the joint has a certain capacity for load and it's a common scenario with patients to come in and say, my knees are done, my feet are done, or my hips done. I played footy when I was younger, or I did all these things when I was younger. Do you think there is any orthopedic cost to activity? And I know some people I've seen online have argued that there may be a potential wear and tear condition where there is a certain amount that you can do before you start to see those changes. Is there any truth to
that? Generally, no. All right, but I'll qualify that answer.
You can just leave it there, just go, nah, and then the next one.
Yeah, so wear and tear is it's a really inaccurate term. And again, it leads patients to believe that physical activity is bad for them. Most joints benefit from activity. I mean, the less you do, the worse the joint tissues will become. And so we know through space travel, through people who've had a spinal cord injury, that the joint morphology is such when it's unloaded that it'll really deteriorate quite rapidly over time. And so we know that trophic stimulus of continued activity is favorable, both for people that have no disease, but also for people with disease. And every joint has capacity for repair. So using the term wear and tear is not helpful for patients, and it's inaccurate. So, I think everybody should move away from that. In general, though, it's that relationship between joint health and physical activity is kind of a U-shaped thing. So if we look at people who have the lowest physical activity, we know that that's not good for joint health. There's a sweet spot in physical activity whereby if you continue to improve their physical activity, they'll continue to improve joint structure and health. Likely, if you do too much, potentially it's deleterious. And when I say too much, it's really hard for me to qualify that. And it's probably an admixture of risk factors that's playing a role here, both in terms of injury and family history. So let me give you a little bit of data. We know that for studies of marathon runners, for example.
Yeah. I'll post about this study. It's a good study.
There's a few of them, but there are some studies out there that suggest marathon runners are at slightly increased risk of developing osteophytes. So essentially the bone spurs that occur at the margin of the joint that may be a reactive thing to loading, and not necessarily just disease and helping to stabilize the joint itself, but they're not necessarily at increased risk of symptoms. There are some studies, preclinical studies that have been done on animals, specifically beagle dogs, where they got these dogs to run repeated marathons, days on, day out on treadmills. And those beagle dogs, when you ran them too far and too hard, did develop osteoarthritis. It's pretty hard to simulate that in the human condition. And we haven't necessarily seen adverse effects of too much activity in the human condition. Again, qualifying that in the context of some types of physical pursuits will predispose people to an increased risk of joint injury. And so when you've had that joint injury and you admix that with too much physical activity, we know that that will increase your risk of osteoarthritis. So I don't want to dissuade anybody from participating in physical activity. Just do so safely, and I guess ideally do so mindful of the principles around joint injury prevention.
What do we think is the primary drivers of pain and symptoms? I mean, I guess, as you said, in the marathon runners, for example, we might see that they have an increased risk of osteoarthritis, but maybe not symptomatic of that. But in the person that has, say, a very mild image and has quite significant symptoms, what do we think could be contributing to their symptoms?
Yeah, no, it's a really important question, and something that I guess people have been tackling for a lot of years. And historically, I guess the philosophy was that this was all related to local nociception, so local pain fibers stimulating why a person may develop symptoms. And we know now that there are certain changes that go on within the joint, specifically synovitis, that capture the distension that may occur within a fusion or a swelling of the joint, and also some changes that go on within the subchondral bone called bone marrow lesions that occur in people that have osteoarthritis and account for a small proportion of the variability of pain. A much larger proportion of the variability of pain relates to the way a person processes this pain. And specifically, we try to conceptualize the genesis of pain and osteoarthritis in a biopsychosocial model. So the bio is that biology of what's happening in the joint, but it's those psychosocial risk factors that play a much more important role in why a person has symptoms. And so that's specifically, concomitant depression, stress, anxiety, catastrophizing, poor coping, and their socioeconomic status that play a really important role in the way that pain manifests and the disability that occurs as a consequence of that. So those sorts of potentially modifiable psychosocial risk factors oftentimes are ignored in our clinical practice, and I think it's really to the detriment of our patient care.
Do you feel like that's seen as we follow someone through a joint replacement? So, for example, if someone does have those psychosocial risk factors, then potentially the joint replacement isn't going to be successful for that person? Or do you still see that a joint replacement is successful even with psychosocial factors of what you just mentioned?
Yeah, so that's probably a helpful segue, and I'm going to get distracted here for a second. About 1 in 4 people that has a knee replacement has a poor outcome. So essentially that means their outcome at 12 months is no better than it was at baseline. And, so that's both a waste of healthcare resource, but it's also exposed patients to a lot of risk and potentially expose them to a lot of discomfort that they didn't otherwise need. We can predict quite well who those 1 in 4 people are by virtue of certain prognostic tools that people like Peter Chung, who's a wonderful surgeon who works with Michelle Darcy at St. Vincent's Hospital in Melbourne, have developed. And so those risk factors for poor prognosis include things like, little if any pain, little if any radiographic change, morbid obesity. But the other really key and important risk factor there is that psychosocial distress, and particularly depression. And so if they have depression and they have that premorbidly, it's very unlikely that that's going to improve as a consequence of their surgery, particularly if it's related to other things other than necessarily just their arthritis in their knee or their hip. So it's incredibly important that be identified in clinical care and something be done about it. And it's very easy for me to sit here as the white-haired ivory tower professor and say, fix their depression. But if you ignore it, it's really to that person's detriment. And they often won't experience anywhere near the same response as a person who didn't have that risk factor preoperatively.
And do you see that in other therapies as well, like injectables and pharmacological and exercise?
Exactly. Yeah. So depression is a really important modifier of response. And so again, if you don't identify it and you don't do anything about it, your chance of helping a person respond to different types of therapy will be mitigated. But in addition, oftentimes that depression will mitigate against a person's longer term adherence to whatever behavioral intervention you want to do. So, if you're getting a person to lose weight, but they're eating for behavioral reasons, it's really, really tough. So, identifying it and doing the best you can to address that, and or engaging someone who can help with that depression.